Good evening from Kuala Lumpur, Malaysia, everyone. My name is Adeeba Kamarulzaman, and I'm the President-elect of the International AIDS Society, and also the Dean of the Faculty of Medicine at the University of Malaya here in Kuala Lumpur. Welcome to the press briefing of the virtual COVID-19 conference sponsored by the International AIDS Society. The COVID-19 conference will take place tomorrow, 10th of July, and will extend into 11 July in the same time zone. This will be the first abstract-driven scientific conference dedicated to the global COVID-19 pandemic. It will feature 140 late-breaking studies addressing urgent questions related to COVID-19 epidemiology, prevention, treatment, and care. We will start this briefing with remarks from Dr. Anthony Fauci, Director of the National Institute of Allergy and Infectious Diseases at the NIH. And then we will hear about several important studies being presented at the conference from 4 other speakers. At this point, the embargo will be lifted for all of those studies. If you have a question for any of the speakers, please type it into the Q&A or type in question, and we will unmute you once you are called on at the end of the presentations. If you ask a question, please be sure to indicate your name and outlet. And also, please, we ask that you keep your questions relatively short. Now we will hear from Dr. Fauci. As you all know, Dr. Fauci has been providing scientific leadership on COVID-19 in the US and globally. We are very delighted that Dr. Fauci will be a featured speaker at tomorrow's conference, and he'll be addressing issues related to COVID-19 epidemiology and therapy. Dr. Fauci will be part of a stellar lineup tomorrow. Other featured speakers will include Bill Gates, Jane Goodall, Dr. Tedros, Dr. Deborah Birx, and Dr. Salim Abdul Karim. Dr. Fauci, the floor is yours.
Thank you very much, Adeeba. Thank you for giving me the opportunity to just briefly outline over a few minutes some of the issues that I'll be bringing up in the presentation tomorrow. You know, as an infectious disease person, I have often been asked over the years, what is the worst nightmare that a public health official could have, and what are the things that we fear the most? And the answer is consistent among me and my colleagues of the emergence of a respiratory illness that is highly transmissible in its efficiency of going from person to person, that has a significant degree of morbidity and mortality. And as a matter of fact, unfortunately for our planet, that's exactly where we are right now with this now historic COVID-19 pandemic. This is not the first experience we've had with coronaviruses. We know the coronaviruses are a group of viruses that account for about 15 to 30% of the common colds that we experience. But in 2002, we experienced SARS, and in 2012, we experienced MERS. This is the third pandemic caused by a coronavirus. It was thrust upon us suddenly and explosively, recognized at the end of December of 2019, which is now, as of yesterday, have about 12 million people throughout the world who've been affected and over 500,000 deaths, involving over 200 countries, and to a greater or lesser degree, getting our globe to, in essence, a standstill. This is an infection that we know now had to be controlled by very draconian methods, namely shutting down virtually every major country that was involved. And where we are right now is in a situation where the world is trying to get back to some degree of normality. And by getting back to some degree of normality is opening up from the stringent public health measures that was able to control the virus in so many different parts of the world. One of the things about this virus that's so unusual is its protein manifestations, which has really caused some confusion about the relative vulnerabilities that individuals might have to being ill. You know, of all the viruses that many of us on this program have had the opportunity to study over years, I've never seen a virus in which you have 20 to 40% of individuals who could have no symptoms at all, namely asymptomatic, to individuals who get mild illness, not even requiring going to a hospital, to people who are confined to their beds at home for weeks with multiple post-viral syndromes, of not being able to get back to normal, to some who require hospitalization, intensive care, intubation, ventilation, and death, particularly among susceptible individuals with underlying conditions. This is completely unique in what we've experienced. Right now, public health measures have been variably successful. We in the United States are having a particularly difficult problem, being the country hit most heavily, both from the standpoint of number of cases and the number of deaths. Right now, we have about 3 million cases, and we have about 130,000+ deaths in our country. Countermeasures we'll be hearing a lot about during the presentation. Right now, there have been, as a result of randomized placebo-controlled trials, 2 therapies that have been shown to clearly be effective. One, remdesivir, in diminishing the time to recovery in people with advanced disease, and the other, a very nice study from the UK, which showed that dexamethasone, when given to individuals who are on ventilators or receiving oxygen, but not in individuals with early disease, which goes right along with the situation of what we know, that it's important to suppress the virus early, but the inflammatory response late. And then finally, in the arena of vaccination, there are multiple candidates that are at various stages of development. One, a UK one of the chimp ad from Oxford, is already in phase 3 trial in South America and in South Africa. The one that was developed, and several were developed through various countries, certainly not just the United States. One is going into phase 3 trial at the end of July, and messenger RNA. There are multiple platforms that involve mRNA, viral vectors, and soluble individual expressed proteins. We hope, and again, whenever you deal with vaccines, we hope that we will have an answer to the safety and efficacy within the period of this year, so that by the end of this year and the beginning of 2021, if we are successful, we might have a vaccine that's available. I'll stop there. Those are my 5 minutes, and I'll wait for later after the other presentations to answer questions. Thank you.
Thank you very much, Dr. Fauci. Now we'll hear from Dr. Andrew Hill of Liverpool University, who will discuss promising results from a study from Iran with Sofosbuvir and daclatasvir, a drug combination currently used for hepatitis C as a treatment for moderate to severe COVID-19.
Thank you very much. Results presented at the International COVID-19 conference are showing significantly faster rates of clinical recovery and improved survival for patients hospitalized with COVID-19 infection who are given 2 hepatitis C drugs, Sofosbuvir and daclatasvir. These results are from 3 relatively small open-label trials in 176 patients conducted in 3 cities in Iran during their first wave of the COVID-19 epidemic. After 14 days of treatment, 94% of patients taking Sofosbuvir daclatasvir showed clinical recovery versus 70% on control treatment. The death rate for people taking Sofosbuvir plus daclatasvir was 5% versus 20% for people taking control treatment. One of these trials was not properly randomized, but clinical recovery rates were still significantly higher for Sofosbuvir daclatasvir in the 2 randomized trials, 96% versus 80%. We need to remember that small open label trials could be prone to biases, so these results need to be seen as preliminary unless confirmed with larger double-blind placebo-controlled trials. Laboratory studies have shown that daclatasvir has antiviral activity against SARS-CoV-2. Daclatasvir also penetrates well into the lungs, where COVID-19 infection can be concentrated. However, in laboratory studies, Sofosbuvir has only marginal antiviral activity. Sofosbuvir plus daclatasvir already has a well-established safety profile in the treatment of hepatitis C, and millions of people are being cured of hepatitis C using this combination. This treatment is being developed with no support from the large pharmaceutical companies. All our funding is from governments, universities, or donor agencies such as Unitaid. If this treatment proves to be effective, it could be made available worldwide as a cheap generic treatment, costing approximately $7 per 14-day treatment course. Sofosbuvir daclatasvir is already available at these prices in India, Pakistan, Iran, and Egypt. There is already enough generic Sofosbuvir daclatasvir mass produced to treat millions of people if this drug proves effectiveness in large trials. We want this treatment to be affordable for anyone with COVID-19 infection in any country. However, in spite of the initial encouraging results, we believe it's too early to reach a verdict on this treatment. We need larger, well-designed studies to confirm our results. We've set up a network of 5 randomized clinical trials to test Sofosbuvir plus daclatasvir in over 2,000 patients with COVID-19 in Brazil, Egypt, South Africa, and Iran. The largest of these trials is double-blinded and placebo-controlled. There are also over 2,000 healthcare workers to be enrolled in trials of prevention. By October, we should know from these trial results if this treatment could be approved for worldwide use. We need to remember conducting research amidst a pandemic with overwhelmed hospitals is a clear challenge, and we cannot be sure of success. Sometimes treatments look promising in early trials, but then fail later on. In future, we will also be evaluating daclatasvir at higher doses and as part of dual or triple combination treatments. Thank you very much.
Thank you very much, Dr. Hill. Our next speaker will also discuss treatment in severe COVID-19, and this will be from Dr. Kristen Marks of the Weill Cornell Medicine in New York. She'll discuss a study that examined characteristics associated with clinical improvement and mortality in patients treated with remdesivir. Dr. Marks.
Thank you, Adeeba. I'm looking forward to the conference tomorrow and appreciate of this opportunity to discuss this multinational research effort with the international audience that's attending the COVID conference. We know that the clinical outcomes of COVID is influenced by several factors, with greatest risk for severe disease and worse outcomes associated with older age and pre-existing hypertension, diabetes, and cardiovascular disease. The objective of this analysis is to examine predictors of clinical improvement of severe COVID in hospitalized patients who were treated with remdesivir, also to determine predictors of mortality. Remdesivir is an antiviral drug. It was superior to placebo in shortening the time to recovery in adults who are hospitalized with COVID and lower respiratory tract infection. A 5-day remdesivir treatment course was similarly safe and as effective as 10 days in non-ventilated patients with severe COVID. The analysis being presented at this conference includes the 397 participants treated with remdesivir as part of this phase 3 open-label multi-center study comparing the durations of remdesivir for severe COVID. The patients were enrolled at 55 sites in 8 countries between March 6th and March 26th, 2020. During this time period, the pandemic was peaking in Italy and moving across the United States. The clinical status of participants was evaluated on a 7-point scale each day. For this analysis, we defined clinical improvement as greater than or equal to 2-point improvement on the scale achieved by day 14. Of the 397 patients treated with remdesivir, 42% were 65 or older and 36% were female. 19% were enrolled in Italy, 12% were Asian, and 11% were Black. Most were started on remdesivir in their 2nd week of illness and within the first few days of hospitalization. In this study, roughly 60% of the patients improved, 30% stayed the same or worsened, and almost 10% died. We found clinical improvement was associated with lower oxygen requirement at the time of starting remdesivir, age less than 65, and Black or white race compared to Asian race. Clinical improvement was also associated with enrollment outside of Italy and not receiving a biologic medication like an anti-IL-6 or interferon. The finding that clinical improvement occurred more frequently in regions outside of Italy likely reflected the time period of enrollment. The racial differences in clinical improvement are explored further at this conference in another presentation. Further studies evaluating combining remdesivir with immunomodulators are needed to establish clinical benefit. The baseline characteristics associated with mortality at day 14 included higher oxygen requirements, such as being on high-flow nasal cannula, non-invasive or mechanical ventilation, having a history of COPD, or having age 65 or older. Thank you.
Thank you very much, Dr. Marks. We'll now move on to Dr. Claudio Fenizia of the University of Milan, and he will share the results of a study that investigated a very important question, whether in utero vertical transmission of SARS-CoV-2 is possible. Dr. Fenizia?
Thank you for inviting me to this venue. I'm really honored to be here talking to you. And yeah, we investigate, the aim of our study was to investigate if vertical transmission is possible in SARS-CoV-2 pregnant women. And also we wanted to investigate the inflammatory profile in these women. So in order to do that, we enrolled 31 women among 3 hospitals in northern Italy between March and April, when COVID-19 hit Italy quite hard at the end of February. So that means that all the women we enrolled were towards the end of pregnancy in the late 3rd trimester. We collected a number of specimens from all the women enrolled in the study, such as placental umbilical cord biopsies, umbilical cord blood, maternal blood, vaginal swab, nasopharyngeal swab of the newborns, of the mother, milk, and amniotic fluid. And we tested all these specimens for all the women enrolled, looking for the presence of the virus. And our results strongly suggest and support the vertical transmission in 2 cases out of the 31 studied. These 2 cases were different cases. We don't have time probably to go over, but briefly, they both have had a positive placenta. Actually, one of the 2 at the beginning resulted negative, but during these days, analyzing other portion of the very same placenta, we figured out that some of them are positive. So overall, we have 2 positive placenta. These 2 babies were positive at the nasopharyngeal swab immediately upon delivery, and one of the 2 had IgM in the umbilical cord blood. And keep in mind that the IgM are not normally transferred through the placenta from the mother, so their presence is therefore consequence of direct exposure of the fetus to the virus, while the other baby had umbilical cord blood positive for SARS-CoV-2 virus. So overall, we believe that our data suggests that vertical transmission during pregnancies is indeed possible. Although 2 caveats has to be disclosed, since first of all, the number of women we enrolled is not wide enough to draw any firm conclusion. This has to be intended as a preliminary study, and also we basically took a picture of the women delivered in Italy during the beginning of the infection. It means that it's a big question mark what would happen if women get infected earlier on during the pregnancies, considering that the 2 putative in utero infected babies were healthy, although positive to the virus. Further on, we studied the inflammatory profile both in the new mothers by their blood, and also the inflammatory status of the fetus, meaning that we analyzed the placenta and umbilical cord blood, looking for expression and release of pro-inflammatory molecules. And indeed, we found quite strong enhanced inflammatory status in infected women compared to negative controls, and which is not really a surprise, but furthermore, also the placenta were extremely inflamed, and also the fetal blood showed really high expressed pro-inflammatory molecules. And that could be detrimental even more than the infection itself during the pregnancy. So really this study has to be meant as preliminary. Further studies should be performed on a wider sample and covering different gestational ages of the pregnancy. But this is a first ringing bell that should raise awareness about a topic that is not often really well studied, such as the impact of SARS-CoV-2 on the pregnancies. Thank you.
Thank you very much. Very interesting. And our final speaker will be Dr. Karina Marquez. She's going to speak on some interesting public health initiatives from a large COVID-19 testing campaign in the US. Dr. Marquez is from the University of California in San Francisco. Please go ahead.
Thank you so much. It's such a pleasure to be here to share these data. So the Unidos en Salud study was a study in which we sought to characterize ongoing SARS-CoV-2 transmission in a densely populated majority Latinx community in San Francisco, 6 weeks into shelter in place. We offered reverse transcriptase PCR tests and the Abbott Architect IgG antibody test to all community members in a defined census tract in the Mission District. Testing was conducted from April 25th through 28th in outdoor community testing events, and this was done in partnership with the Latino Task Force for COVID-19, which is a group of local community-based organizations and leaders. This study was one of the first SARS-CoV-2 universal mass testing campaigns in the US to do both PCR and antibody tests. So what did we find? Well, testing demand was high. Within 4 days, we tested 3,953 census tract residents and people who work in the area. Testing coverage was over 60% of the census tract. And the estimated prevalence of PCR positive infection in the census tract was 2.3%. And disparities were stark. 95% of the people who were PCR positive were Latinx. Drivers of infection were largely economic, and 93% of people who were PCR positive were unable to shelter in place and maintain income. The estimated cumulative incidence of infection, that is the people who were either antibody positive or PCR positive, was 6.3%. Antibody positivity alone was 3.1% in the census tract. Offering PCR and antibody tests at the same time allowed us to characterize how the risk for infection changed during shelter in place. Prior infections, that is those that were PCR negative but antibody positive, occurred across a greater diversity of ethnic groups, employment types, and household income strata. However, when you looked at recent infections as discussed previously, PCR positive, these are infections that are PCR positive antibody negative, they became increasingly concentrated among low-income Latinx frontline workers. We also looked at the proportion of asymptomatic infections on a community level. We found that 53% of PCR positive patients were asymptomatic at the time of testing, and 42% remained so at 2 weeks follow-up. Symptom-based screening would have missed the majority of people with PCR positive infections. We also looked at median levels of virus by RT-PCR cycle thresholds and found that they did not differ between symptomatic and asymptomatic people with recent infection. And lastly, phylogenetic analyses revealed high sequence diversity in the census tract, including 5 globally circulating clades, suggesting multiple independent introductions of the virus into the census tract over time. Additionally, 58% of the PCR positive participants shared a home with another PCR positive participant who tested at the campaign, and sequences were consistent with within household transmission. Our phylogenetic data suggests that most recent infections during shelter in place are due to acquisition of the virus when working or seeking work with subsequent within home transmission. So what are the implications? Well, improving access to SARS-CoV-2 testing, regardless of symptoms, through community-led, low barrier testing programs in vulnerable communities, coupled with economic support and protections for low-income workers during isolation and quarantine, are urgently needed to reduce community transmission and address the massive disparities observed in San Francisco and throughout the United States. Thanks.
Thank you very much, Dr. Marquez. We will now open the floor to questions, and like was mentioned before, what you need to do is to type in the Q&A box, and please indicate which which publication you're from, and who you want to direct your questions to. We already have a few questions here. I'm going to start with the first one for you, Claudio. This is a question from the NBC. I don't have the name of the journalist, but the question is, we were wondering why newborns, even after being diagnosed with COVID, seem to fare well. Is there anything we can learn from that?
So I do confirm that both babies were healthy and in good condition. And even if one tested positive repeatedly for approximately a week, and the other one was positive just right after birth. Anyway, I would say that considering the fact that the mother were infected less than 2 weeks before delivery on average, really, even if I'm not a clinician or a pediatrician, I wouldn't expect too much of an impact of baby development or any other health parameter.
Thank you. I have another question I have two questions for Dr. Fauci from Donato Mancini from Financial Times. What are your thoughts on the Sofosbuvir daclatasvir combination result that was just presented by Dr. Hill? And what are your thoughts on dexamethasone? Should it become standard of care?
Well, the results that Dr. Hill just presented were really quite interesting and provocative and encouraging. But as he mentioned, the important thing we need to do is to get these kinds of studies into a randomized controlled trial. But the preliminary information that he presented, I think, is really quite interesting because for a number of reasons. One, we desperately need antivirals that can be given early on in the course of disease to prevent individuals from going on to require hospitalization. So I would encourage, as he did himself quite clearly, that we do further studies on this to nail this down in a randomized controlled trial. With regard to dexamethasone, well, the study from the UK is really quite impressive. If you look at the effects of individuals on ventilators, individuals requiring oxygen, and then individuals with early disease, it was very clear that it was highly significant diminution in mortality in the two groups that were either ventilated or required oxygen, but not in the early group. That is very important because that goes along exactly with what we know about pathogenic mechanisms, namely that early on you really want to block the virus but keep the immune system intact. And later on, when you have aberrant inflammation, you want to dampen it. The United States, the NIH has put together a clinical guidelines group, which is an online real-time living document that we continually upgrade and update the recommendations. And we are recommending, based on this, that dexamethasone in patients under the particular criteria that we use in the study be given dexamethasone because of the diminution in mortality. So in many respects, it is now becoming standard of care for advanced patients on ventilators and or requiring oxygen.
Thank you. We have a few questions for you, Dr. Fenizia. The first one is Sipukatsi Fokazi, a journalist from South Africa, who would like to know if you did any testing on mother's milk, and if so, was it safe or was it safe for them to breastfeed?
So as for any other part concerning our study, it's really way early to draw any firm conclusion and like suggesting guidelines on anything like that. However, we did find one positive milk out of all the samples collected. When I say positive, I mean that was PCR positive, and it's left to be assessed if it's actually an infectious virus. And so I wouldn't draw any firm conclusion about that unique sample we found.
Mm-hmm. And another question to you. were there any consequences for the children after birth, and could there be long-term consequences?
So, so far, we are not aware of any detrimental consequence for these two babies. Although, of course, the longer the follow-up is, the tougher it is to really follow and be up to date. And however, again, there were just 2 cases, so it's too early to assess the potential long-term risk for COVID-19 putatively infected babies.
Okay, thank you. This along the lines of children, but this is more from a public health perspective. Dr. Fauci, a question for you from Lisa Krieger. I don't know which news outlet she's from. Do we know why children are not efficient transmitters of COVID-19 infection? And what might that mean for school reopening? Do you have any thoughts or recommendations regarding school reopening?
Yeah, well, that's a very important question. And I think there's an assumption that we know for sure that children are poor transmitters, when as a matter of fact, we don't have enough data to make a definitive statement in that regard. There is some suggestions that they are poor transmitters. They certainly clinically, obviously have much less of a chance of having an adverse outcome, except maybe for some early studies showing children very, very early, newborns. But in children, you know, at school age, which I think was the basis of the question, right now we are doing a natural history study on 6,000 families in the United States to determine definitively whether that suggestion and that statement that the reporter asked is actually based in actually scientific data. Are they really poor transmitters or not? Because that does have obvious implications when one thinks in terms of opening schools. The issue with schools is obviously a hotly debated topic about making sure that you get children into school, because of the ripple effects of keeping them home may be deleterious in many respects. And on the other hand, you want to make sure that you account for and care for and are sensitive to the health and the welfare of the children. So this is something that is really, you know, a very difficult issue that is being grappled with in the United States, and I'm certain in other parts of the world.
Indeed, yes. And moving along to questions on long-term effects of COVID-19 addressed to all the presenters. Question from Terry Wilder from the Body Pro. What is being done right now to address the long haulers' risk for developing myalgic ME and chronic fatigue syndrome? A percentage of long haulers will end up having this. There has been very little funding invested in research on this complication, and few medical providers know how to take care of people with ME, chronic fatigue syndrome. There are no approved drugs. So I guess the question is what can be done and what should be done?
Well, we have a natural history study, Adeeba, asking and hopefully answering that question about looking at people who are recovering and have recovered from illness that was clinical illness, obviously not asymptomatics, but clinical illness. And the suggestion that Terry Wilder, who I know from other experiences, is asking a very relevant question. Because if you look anecdotally, there is no question that there are a considerable number of individuals who have a post-viral syndrome that really in many respects can incapacitate them for weeks and weeks following so-called recovery and clearing of the virus. If you just do anecdotal questioning of people, and in fact, there are chat groups that you just click in on and you can see people who've recovered who really do not get back to normal. They have things that are highly suggestive of myalgic encephalitis and chronic fatigue syndrome, brain fog, fatigue, difficulty in concentrating. So this is something we really need to seriously look at, because it very well might be there is a post-viral syndrome associated with COVID-19.
Yes, very, very troubling symptoms many are describing. A question again for you, Dr. Fauci, from Pierre Douali. How do you calculate the number of COVID-19 deaths in the US? In Belgium, the authorities calculate the suspect cases and not the confirmed cases. Don't you think that there should be a standardization of the data on a worldwide level in order to compare the data with each other?
Yes, there should be. I mean, yeah, we do both. I mean, I think if you look at the suspected versus confirmed, there's not a major difference in the calculation in the United States, but we do both. But it's true, we should have a standard way of calculating that.
There's a few more. Sorry, back to you, Dr. Fenizia. According to the Pregnant Women Study, when should COVID-19 tests be done at which month? From Nicholas Rodriguez.
Well, that's tough to say, but probably better safe than sorry, I would say. So prevention should be following the safety rules that pregnant women should have already been following, should be a must, in my opinion. And so why not testing these women earlier on, as soon as the COVID-19 diagnosis could be done on these women.
Okay. Here's for you, Dr. Martinez, from Liz Heileman, Bay Area reporter. Will you be testing these people repeatedly going forward to observe trends? And are there any plans to do similar studies as well elsewhere in the city?
Thank you. We are planning on doing repeat testing of the census tract. And then this model has already been used in other areas of San Francisco, including the Southeast sector. So it's certainly a model that we hope others will take up.
Okay. From Marilyn Marchione at the Associated Press, nearly 200 scientists recently wrote to the WHO about the possibility that SARS-CoV-2 is spreading airborne. Dr. Fauci, please comment on the evidence of this. Airborne transmission.
Yeah, there's always an assumption. It depends on what you mean by airborne. I mean, I'm pretty sure that Marilyn is referring to the situation that we actually experienced in a single episode during the SARS outbreak, when there was transmission within a hotel that went from one floor to another. It was felt that got into the air system and traveled. If that's what she's referring to, namely really distant, where you go into a room and many, many minutes later, after a person is there is no solid evidence that that type of transmission is occurring, although you cannot rule that out completely. So what we do is we have an assumption that there is some evidence of airborne transmission, which is really the fundamental basis of why we are now so much intent on getting people, particularly people without symptoms, to wear masks to be able to see if we can mitigate against that. So not a lot of solid evidence, but I think a reasonable assumption that it does occur.
In relation to that, a question from Simon Rosé from Radio France International to you too, Dr. Fauci. As far as we know, social distancing is the most effective way to prevent infection, yet we see more and more contestation from the public to follow these rules, including wearing masks. We witness mistrust to official and scientists' advice. How, as a clinician and authority, do you think this issue of trust should be taken care of?
Well, it's a difficult question with not a very easy answer. I mean, obviously, we're in the United States. For those of you who are paying attention, we have a real difficult situation of almost like a division among those who swear by masks and those who deliberately don't want to put masks on. That's really very difficult. We're trying to get some degree of unanimity in the response to the use of masks and social distancing, because we know factually that in those areas, those countries that practice social distancing and the wearing of masks, particularly when we shut down, we saw how the number of cases have gone down dramatically, not only in the United States, but in any country that practiced shutdown and social distancing. It went down. So we know that it works. The question is, there's the pent-up need now to get back to some sort of normality. We've got to overcome that need to do that prematurely, because when you do it prematurely, you see what we saw and are seeing right now in my own country, in the southern and southwestern parts of the country, in which we are having substantial resurgences of infection in states like California, Florida, Texas, and Arizona, where there have been a getting back to normal, as it were, which has been really contrary to the social distancing. So I agree with the questioner that this is a very difficult issue to get the community of people involved to practice by those guidelines.
Yeah. And another one to you from Jeffrey Berry from Positively Aware. Given the protein nature of this virus, what implications does that have for treatment and vaccine development? Could someone conceivably be given both at some point in the future if testing positive?
I'm not sure what he means, given both a vaccine and a treatment. Is that the question? I don't really quite know what he's talking about. Vaccine is for prevention. I'm not sure why you would give a vaccine to someone who was already infected, particularly if they had symptoms. You'd want to treat them. Sorry.
Okay. One for you, Andrew. Where is that question? You mentioned the need for further randomized controlled trials to confirm your results. Are they ongoing or planned in the near future? A question for you, Andrew Hill, from Simon Rose.
Okay, so there's a double-blind placebo-controlled study just started yesterday in Iran with 600 patients. There's a study in Egypt which is already recruiting. The Egyptian study program is 550. The Brazilians are planning to start with 720, and the South Africans are starting with 200. We're at about 2,000 total. We should have results within the next 10 weeks. So by early October, we're aiming for, but the epidemics are very hard to run trials in. Some of the doctors working on the trials have actually got sick themselves. So we're trying our hardest.
Okay, here's a follow-up question on the dexamethasone and remdesivir. Has dexamethasone supplanted remdesivir as a standard of care for patients requiring oxygen and/or intubation? Anyone?
If this is a question for me or for
Kristen? I think it's for Kristen or Dr. Fauci.
Oh. I can start. So I think, in both of these studies, we realize that not everyone does well with each individual treatment. And for particularly the sickest patients, I think we need probably to combine things. So I'm excited to see data on the combination. We're actually looking at that, collecting who got steroids in this study and trying to kind of sift through that data. I think that's looking at combinations is going to be important moving forward. But for sickest people, I would give them both.
Okay. And I think we have time for just one last question from Heather Borner at Medscape. A question to all the presenters. Research is happening at an amazing pace, but so many of these findings are preliminary or, in the case of the vertical transmission case, possible. What are clinicians who have been run ragged for months and overwhelmed with fresh cases to do with these findings? What do they mean for providers? Could you speak directly to them, please? Anyone?
Well, that was the reason why we put together the panel, which is recommending we have a group of experts from multiple diverse fields who look at the data as they come out in real time, both published data and what we're seeing more of now is pre-publication information that comes out in non-peer-reviewed journal. The questioner is absolutely correct that the clinicians are really starving to get information that they could use on their patients in real time. And that's one of the reasons why you like to get a guidelines panel, which we do have, that hopefully analyzes the data for them.
Yeah, I would echo that. I mean, I think having gone through feeling so desperate to help people and try new things, it's really important to do these clinical trials. I think we find some of the things we thought had the best hope turn out, not to be effective, and then whereas others are, and it's really hard to predict that. So it was really helpful as well to have a national guidelines to help guide, because you get tempted just to kind of throw anything at people. And I think we really have to have science guide us.
Okay, perhaps one last question for you, Dr. Fauci, because Mr. Mancini from, I think it was Financial Times, just really want to hear from you if dexamethasone has supplanted remdesivir as the standard of care for patients requiring oxygen and or intubation.
No, I think that Kristen answered that question. Very
They're not.
Yeah. Dexamethasone for certainly ventilated patients and patients with oxygen, but remdesivir, I mean, the real issue is the combination. Should we really be using combination? And that's the study that's being done. So I don't think you could say one has supplanted the other.
And there are different mechanisms. So, it makes sense to combine them.
Yeah.
But they wanted to hear it from you, Dr. Fauci.
Well, Kristen, you said it perfectly clearly.
Okay. How are we doing for time? I guess one last public health question from Leonardo Bastida to Dr. Karina Marquez. Which are the social determinants that impact on Latinx population to record this high prevalence of infections?
Thanks so much. In our study, I think the primary drivers of the high prevalence in the Latinx population in our study were really the underlying inequities that exist, and primarily economic drivers. Most of the people that had PCR positive infections, so the recent infections, didn't have the privilege to shelter in place, were out working to support their families, and were primarily low-income frontline service workers. And so I think these economic factors and structural inequities really drove these disparities during this time period in shelter in place, which there was some difference when you compared sort of the recent infections compared to the older infections that were antibody positive.
Okay, thank you. Well, I think our time's up, and thank you for a great panel and for taking all those questions. We're all looking forward to the session tomorrow. So thank you to all speakers, and have a good session.
Thank you. Thank you for having us.
Thank you.
Thank you.
Thank you.
Bye.
Thank you.